Hello, everybody. Thanks for coming. I'm glad you're here. I thought everybody was going to go home already. There is a typo on the first slide. Usually I catch them, but I didn't catch 2023. I don't know why I'm ahead of myself, but I'm already into next year. It is going fast, but I don't want it to go that fast. So this is a little bit of an unusual presentation in that there's so much changing in rural health clinics right now. I don't have all the answers to every slide. I hope some of you will. I'd love to invite some great discussion on some things that are not quite in my wheelhouse. Okay, so first of all, the PHE, he said it today. We also feel it's going to go in January, go till January and be done. Okay, so we're going to show some really interesting things that CMS has put out about some individual waivers specific to rural health clinics. The secretary said he would give us 60 days notice. So that means next week we'll get notice that it's extended. And then shortly, well, about a month later, we'll get a 60-day notice if it's going to end in January. So we have to wait for that, but we will likely get there. I think it has to wait till after the midterms. That's my read on it. Okay, so one of the big subjects this year was HPSA withdrawals. That was also a nice extension. You heard that that's extended to 23. My point on this slide is to get your clinics to call their primary care office and get working on their HPSAs. Because we have clinics calling us that want to move, want to go into a new area, and it's set for withdrawal and they're afraid to do it. So if the state, usually the primary care office in each state will work on the HPSAs, and then they do their work, and then it won't be withdrawn. And some states are really actively working on it and some are not. So if you have clinics in that category, please do. Lisa, is there a question in your mind on that one? You agree with me? Good. I'm glad to hear that. When she agrees, I'm in good shape. So we want to make sure she knows her stuff. Good stuff. Now the HIPAA, this caused a great furor at Torch 2 weeks ago. So Sarah Bodeman is a HIPAA expert. And she stood up there in front of quite a few people and said, if you have a release of information blank form in your new patient packet, get out of here and get it out of there. There are OCR fines for that. You cannot have that in your new patient packet because the patient signing a blank release of information to whom, for what, you have no idea. And they've signed it and they can come back at you. So that must go. She said that was never allowed. So it caused, I mean, people were on the phone. It was quite interesting. There were a couple hundred people in the room. So really, so the patient should only be completing release of information forms when there's an actual need for the authorization. And I won't read that to you because you'll have these slides. Most importantly, though, is that in March of 23, all these changes are coming on HIPAA. It's going to get tighter than ever. In one respect, I say tighter, but in another looser, allowing patients to inspect their PHI in person and take notes and photographs from your EMR. I just can't even believe that, but that's coming in March. So all the, yes. Yeah. You cannot have blanket forms. It's specific to whatever they want it for. And fact is, as I heard her say it, you're not even allowed to, they don't have to give you their signature to get their own records. So the law is changing in March. Yes, in the federal regulations for rural health clinics, it clearly says signature for records. So that's going to be, we're going to have to get CMS to read on that if the HIPAA becomes stronger, that we can't allow that, get that signature. So I don't know where that's going to go yet, but that's a good question. But no blanket forms at all, none. Okay, so let's go back to what's coming. Changing the maximum time you can provide access to PHI from 30 to 15 days. So you're going to be pushed to do that. Requests by individual to transfer their PHI to a third party will be limited to ePHI maintained in your EHR. Individuals will be permitted to request their PHI will be transferred to a personal health application. So I'm not quite sure. Anybody can explain that one to me? What does that mean? I meant to look that up and I forgot. No? What is your personal health application? Somebody you pay for to log in your PHI? No, we don't know. So we'll find that out. States when individuals should be provided with EHI at no cost. That will be a state-specific requirement. If your state says you can't charge them to print out that 100 pages or your ink and paper. Covered entities will be required to inform individuals that they have the right to obtain or direct copies of their part of their PHI to a third party when a summary is offered instead of a copy. I mean, this is just a summary of what's coming. So we're going to need more information on HIPAA as the time gets closer, and hopefully NRHA, NARC, NOSOR, somebody's going to do that kind of education. That is not my area of expertise. I worry about on site, we worry about pieces of paper that we see with PHI on it, or computer screens that don't time out, those kinds of things. Of course, you have your clinics have the responsibility for the social media for PHI. Yes, Scott. Right. Oh, okay. So that's what you're referring to. I think so too. Okay, good. All right, good. Thanks. You must post the fees if your state allows you to charge on what your fees are to copy PHI. I mean, it goes on and on. I just wanted you to get a feel for this, to know it's coming, and we're going to have to provide some education by someone who's skilled in this, not me. Okay, very, very important. I just wanted to get, my topic was what's new, what's changing in rural health clinics. So I wanted to throw that in. You'll notice I did not put any billing slides in. That is clearly not my area, but telehealth, audio only, all that. There's going to be 151 days past the end of the PHI for the government to sort that out, and we'll all get our answers as we go. NARC does a great job of keeping us up to date on the billing issues. So workforce issues are still a problem. There is a document, I meant to put a link. The document is called CMS Blanket Waivers _524 2021-508. This came from that document, the next few slides. This is going to have some amazing information at the very end. So this one talks about the staffing requirements that were waived during the PHE. And right now that would, let's just say it's January 14th. However, look at that last line. CMS is exploring options to make this flexibility permanent. Now, they don't have much time if they're going to make it a permanent flexibility, but just so you know, it may not go away. Maybe that waiver will stay because we have incredible workforce challenges. We have clinics closed 1 day a week now, closed on Tuesdays, whatever, or closed because of staffing. So it's good that the government's going to reconsider that and give us some grace on that. We hope that's true. That's on the 50% hours, right? For NPs and PAs. Okay, policies match. This is out of order. Policies matching the process. So when we see a clinic that has, let's say they say annual review of policies in their policy, but the federal government says every 2 years, except in Louisiana, right? Guess what? They're going to get cited because you're cited to your policy, whichever is the most rigid, right? If they said 4 years, well, that's not going to fly because the government says 2. So they must look at that's why we review policies. We review policies and then we find something like, oh, we changed that process. We're not doing it that way anymore, right? So we all do that. And you need to look and make sure your policy matches your process. To me, and that's why I wanted to tell you this, to tell your clinics, it's a citation you don't need. It's just not necessary to take that citation. Let's get our policies matching what we're actually doing in the clinic, okay? So that's the most common one. Oh, and a very common one is annual consent. There's no federal regulation for that. But if you have annual and your patients that they look at that review came in and didn't get a new consent, you'll get a citation. So clinics need to know these kinds of things. That's a biggie. Now, the reason I put this here, this was just from our own training. These are ideas from clinics. You may not like this ideas. They don't really jump out at me either. But my point is, in your states, talk to your clinics, find out what's really working well in a clinic and share the wealth around your state. Do it in your newsletter or in your calls, whatever you do to communicate to clinics, so that if somebody comes up with something really stellar, we tell somebody else about it, right? It's really a great idea to share. And that's what we're going to do, put some ideas into our newsletter because it works. Do you need an anaphylaxis kit aside from your emergency box? I don't know, but if you want one, that's a great idea. You have it, run and go as often as you would need that. They all need to know, all your clinics need to know, do not move unless they check with you or with their primary care office. They are grandfathered in where they sit. But if they move next door, and we have had this happen, I can think of a clinic in Texas, bought the ground, built the building, and they're no longer a rural health clinic. And there was no winning because that whole area had gone out of being in a HIPSA. So those things are important. Any change beyond that, a name change, I can't tell you how many times we drive up to a clinic and the name is not what it was 10 years ago, whatever, or the last time they were seen on their 855. You must report name changes on an updated 855A, any information. The medical director is a reportable event. That's done on a CMS 29. And you send that to the state and to the accreditor if you're with an accreditor. Okay, so those changes you make are very important to report. So there was a clinic in California that completely changed its name, never told the state. They were state surveyed. They called us for help. The state surveyor drove up, saw the name was Scott's Rural Health Clinic, and when it shouldn't have been, and drove away, completely failed them. It's because that clinic wasn't there. It was there. It just changed names. So it's, state surveyors can be a little, we would have gone in and cited everything under the sun that wasn't the right name, but they would have had a chance to fix that very quickly. The state surveyors do things a little bit differently. It's why accreditation, and Shauna can tell you that, it's really good to be accredited, not just certified. Everybody understand the difference. You all would, I think, being state offices, between certification and accreditation. Yes, nods, no. Okay, so CMS is the only person that can certify a rural health clinic. And if you want to wait, when you're starting a new clinic, if you want to wait a couple years, they'll come out and certify you. If you want to be done, that's the truth in most states. But if you want to get through the process quickly, and that's the first reason you use accreditation, you call Quad A or us, and we accredit you. So it's a step above certification, but it gets you through the process quicker. But the reason to stay accredited is that regular, continuous visits every 3 years, midterm attestations that you're still, so you don't get this surprise visit. And we have clinics that in states that we talk to that aren't seen for 6 and 7 years. And it's easy to go sideways on the regulatory things. They're busy taking care of patients, not thinking about all the things that are in the federal regulation at 491, right? So accreditation is a higher step, if you will. Okay, physician supervision is another one of the waivers right now that's waived, but look at the last line. This flexibility is currently set to return to PHE rules at the end of the calendar year. The PHE ends. Get that. That's a different one. That's why this document was such a shock to me. They all have a different kind of spin on them. This is going to, so if it ends in January, the physician supervision waiver won't end till next December of 23. You read that? And CMS is exploring to make this flexibility permanent. Very, very curious on this one, because physician supervision is different in states. We would love to have that be the same in states. So anybody from Washington State? No? I had a young NP male call me. He wanted to become a rural health clinic. He didn't investigate all the pieces and parts, because when I talked to him about a medical director and somebody reviewing his files, he said, no, we have autonomy here. I said, well, that's great. Do you want to be a rural health clinic? He won't go. Nobody's looking at my files. They fought hard for that autonomy, and I get it, but he's not a rural health clinic. So we would love that to be an NRHA. I'm on the board at NRHA, and we are working hard at that to make some autonomy through the states. You've heard a little bit of a reference to it earlier today from one of the speakers. But so I want you to take note, the document that you should download that I gave you has all these little extra sentences at the bottom of now it's a 30-page document, I think. So it's got every entity there is. So if you're doing hospitals and whatnot, that's in there as well. Okay. These are all little just tidbits. The temporary expansion location, which has been used widely, I will say quite frequently with pediatricians. So it wasn't designed for this, but during COVID, we'd taken an office location somewhere else in our community, maybe down the road 10 miles, whatever, in another town, and see either sick or well children. And they did it because they could. They were separating for good reason with COVID, but they were also analyzing the neighborhood. And they got a chance to see, oh, is that a good location for a clinic? Let's put one down there. It worked. It's busy. So it was a nice little side benefit for a couple of tough couple of years. Yeah. Oh, well, thank you for that. I didn't say the name, so you don't know who to go to. Don't worry. It's not a rural health clinic anyway. Thanks. I would never, usually I don't even say the state, but you have to know it was an autonomous state. So at any rate, on the temporary expansions, that's not staying. And you can understand that. You want to be a rural health clinic somewhere else, you're going to have to go do an 855 and go. So this one doesn't surprise me in the least. So that will go away as soon as the PHE officially ends. Okay. So when you talk to your clinics, teach them how to do a mock survey, a self-survey, if you will. Find a way. Be ideal if, especially the state surveyed folks, we're doing it for them if they're accredited, but not if they're under the state. So they don't get caught with their pants down. So give them a way to help. And they're going to hold a kickoff conference just like we would, chat with everybody in the staff, give them assignments, do a walkthrough of the clinic, have a red pen in hand, have some kind of checklist that either you made up or you can have ours, and then sit down and look at the policy book, and then give some assignments out and find out what we're not doing that we should be doing. So they're always company ready, no dishes in the sink, and this living room's picked up, be ready for anybody to walk in your door at all times, as we should be. Because like I say, you are so busy, they are so busy with patients many times, they don't stop to think about all these other things that are required. And of course, that's what surveyors look at. Yes.
Still do the training session for state officers to teach them how to do it?
Absolutely. Yep. Mm-hmm. We do a lot of that. Yes, absolutely. Yes. Right. So after you do those first 3 years, you have a choice as a rural health clinic, and it costs money to be accredited like everything else. So we have staff to pay. They can go back to the state or they can stay with us. No, they stay with us. Yeah. 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 We have some renewals up there. Yeah, exactly. I wanted to comment on something that Tammy said, though. What Rashawn and I cannot do mock surveys. We're not permitted to do that. Every survey we do is reportable to CMS. There's no pretend surveys. We can teach it all day long to other people to do. Yeah. So as state offices, let me caution you on one thing. Before I do mock survey training for you to offer as a service to your clinics, make sure you have it solid what you're going to do when you see something egregious. Okay. How about a safe at the nurse's station with 10 opioid prescriptions signed by an MD that does not even work in the clinic? What are you going to do? That's pretty egregious. That's a DEA call. But you want to, it's a hard one for you. And I've been down this road. That's why I say this, because you want to build trust that you're coming in there to help them. But if you find something really egregious, that's a real problem. You got to know what you're going to do. And that's a bad one. That was our survey, by the way. We did have to report that to the DEA. Okay. So the nurse practitioner was handing out those pills to an MD that had never seen it. She's shaking her head back there, but she's probably seen worse than that too. Yeah, we see it all. We see it all. So after you do your mock survey walk around, have a wrap-up conference and celebrate it. They worked hard to stay compliant. And let me say this, compliance is not a one-person job. You could never keep your eyes on everything in that clinic that needs, we're regulated. Are we regulated, right? There's good medicine, and then there's all the federal regulations. So all of that comes in play. So make sure that you celebrate it and give lots of assignments. And then when the surveyors come, so we walk in the door, show ID, and you must see ID, both photo and business card in our case. And then we sit down in the waiting room and we're observing every second, the waiting room, the safety, the cleaning, all of that. And they run to the back and say, they're here, because they're all unannounced, right? And so it usually takes a few minutes till everybody gets their blood pressure down till they come back out. But it's, if you're ready for company, they're coming. When you're in the window, for accreditors, you never know with the state, but you do with accreditors. So be calm about it and know you've got it covered. You did it right. This is our checklist. You want to do some sort of a list if you're going to do a mock survey, to make a self-survey to make sure you're in compliance. Think of the survey box, those check boxes, as the surveyors have to check every box. They can't leave any blanks. So a simple one, if you didn't address volunteers in your emergency preparedness plan, simple thing, you're going to get a deficiency. Well, it's either right that ABC Clinic has decided not to utilize volunteers in our EP plan. We know that came from hospitals. We don't see volunteers in rural health clinics. But if you're going to have them, then you're going to name them, HIPAA train them, and train them on your emergency preparedness plan. So one or the other. So write a sentence in your policy that says we're not using them. In Idaho, there was an incident in a waiting room with a very out of control patient. And the volunteer was another patient in the waiting room who helped the receptionist out by getting up to try to calm the fella down. He was the one that the volunteer was the one that went to the hospital with a broken nose because this guy was out of control, but he tried to help. So that's who your volunteers are. They're your family and friends when there's an emergency. I'm sure in Florida, some of the clinics to get stuff out of there before the place would be wrecked by wind and rain were the family and friends of the clinic, right? And so, and able-bodied patients. So we don't really see volunteers much written up in rural. Okay, so medical assistant education has become a hot button for me. We are finding, and I'm talking about MAs, not CNAs. MAs could be, in Kansas, it could be a week training, 1 week, OJT. We have found more than I'd like to even admit, MAs who don't know the difference between a single dose vial and a multi-dose vial. A single dose vial with a 28-day date on it. Any clinicians? I know we have a doctor, but any other clinicians of any kind, nurses in the room? No. Single dose vial has no preservatives in it. That's why it's one patient and in the trash. And if you put a date on that for 28 days, like you do a multi-dose, you're giving perhaps unsafe, perhaps ineffective medication. That is a failed survey, one vial. Okay. And we're finding it and finding it and finding it. I actually had it on my to-do list to talk to Tammy about some kind of MA education that we could offer to get these people up to speed. Don't assume they know. Go get it out to your clinics. I don't want to see that anymore. And I got lots of slides on this because it's an issue. And it happened last week in a survey. So we cannot have this happening. It's not safe medicine. And seriously, I'm amazed that we, as a nurse, and I'm an old nurse, you picked up a vial, you even held it up to the light to see if there's anything floating in it. You looked at the drug, you looked at the dose, you looked at the expiration date, all of that. You don't just pick it up and draw something out, ever. And so if they haven't been properly trained on that, it's a critically important piece of it because it's all about the patient. All this is about good patient care. The heck with, well, I shouldn't say the heck with regulations, but that's what it's all about. So we need to make sure that's happening. So make sure they know the difference. Okay. So, I mean, you'll see, I left these in here to make the point because I speak on this a lot and those vials are critically important. On the multi-dose vials, they're opened and dated for 28 days. All right. And then they're discarded. And there are many clinicians, some MDs who want to keep it till the bottle's empty. And you can't do that. You can't do that. I get it. Cost savings. We've had a problem with lidocaine coming in 100 milliliter bottles throughout COVID. I don't know why they ran out of little bottles and that's such a waste. But you got to do what you got to do. Manufacturer's instructions always. So this clinic up in the Northwest part, I want to say one of the Dakotas knew they had a problem. And so they got this little bin and they had one nurse a day who was going to mind those vials. Right? You couldn't put a vial back in the closet and they found their culprit and they did have one, but they solved it and they worked on it internally to fix the problem. So they're not going to have any unsafe medications. Okay. This is a big problem again, 51% rural health clinic services. Now, we had a survey a couple of weeks ago, and we'll not even tell you what state. They were about 80% substance abuse clinic. And it's a nightmare to measure. We're begging CMS for an answer on this. How do you want it measured? There's lots of ways. Is it the primary diagnosis? Are they codes, the billing codes? Should we look at all the appointments for today and see what they came in on? Well, lots of different ways, many which could go sideways. 15 charts that you're looking at, 20 charts isn't going to cut it. So and that happened actually in this one, 80% of the charts were substance abuse, but you can't write that in a report because they have 1,000 patients or more, right? So it needs to be fixed because we're seeing more and more mental health because we need more and more mental health. We're also seeing orthopedics, dermatology, and everything else under the sun. So this is something that NRHA has in a bill right now to do away with the 51%. What it's going to look like is anybody's guess, but a different ratio and mixture as long as we are seeing primary care medicine, which is what the Rural Health Clinic program was designed for. So it's a really problem. That's from Appendix G, that quote about what it means to be primarily engaged. It is a big issue. And again, the federal government is dumping millions into substance abuse and the opioid problem. And yet we're limited at a rural health clinic. There's a clinic in Missouri who sent one of their physicians to be Suboxone trained. And obviously this little town had a problem. They were overwhelmed with patients. And he got audited by state survey. Again, nobody's clear on how they measured it. And he went to Baltimore to fight it, the CEO of the hospital. He happens to be an attorney. He lost. They had to move the physician or not be a rural health clinic. The nearest place they could put him was 8 miles. Now, you and I know those patients that needed that Suboxone may not even have a car. There's no bus. What happens? That's just not right, right? So there's a lot of issues on this one to work on, especially with all with the drug culture and what's going on in our country. And like I said, NARC and NRHA have actually come together, which is delightful to see, on a proposal to Congress to fix this. Okay, for emergency preparedness, a couple changes happened last year. Your hazard assessment must include EID. That's new. Emerging infectious disease. You've all lived it for 3 years. Now you've got to have it as one of your risks. I hope they're not planning on another one because it's been painful. So, and then your exercise, if you list 5 subjects for your emergency preparedness as your risk assessment, you must choose one of those things for your exercise, not an event. An event's an event, but for an exercise. So let's say my clinic's in Pennsylvania where I live, and I choose to do an exercise on tornadoes. The surveyor is not supposed to accept that. Well, if I've listed tornadoes, but I live in Pennsylvania, I think we get one every 20 years or 30 years or something like that. Not very often. We're not in Kansas, right? So why would you exercise on something that you're never going to see for sure, right? So, but EID must be in there. And then refer to your risk assessment to determine the training and testing is reflecting your risks, okay? Communication plan is complete. Wow, this is another citation that seems sad to get. You're going to write down the name and phone numbers of federal, state, FEMA, local, county, all those phone numbers in your emergency preparedness plan, as well as everybody that works in your clinic. To not have that, it's a citation you don't need. Just do it. Now, as people ask me all the time, so Mary left our clinic 3 months ago. We didn't go in and update. I don't think anybody scrubs it to that extent. Training, we will, but not on that EP. The numbers are there. Keep it updated as best you can. Yes. Okay.
Our state is paying for medical, and this rule is true. Do you have any comment on?
Oral health is a approved CMS service in a rural health clinic. It's paid by Medicaid because Medicare doesn't care if we have teeth. But no, they don't pay for any dental. So, well, maybe some kind of major stuff. So I would, well, she's going to have to watch 51% on that, right, Chan? Yeah, she's going to have to watch that she doesn't go over 51%. That's a heck of a dental practice. Yeah. And we need dental because if we have kids that don't get to the dentist until it's way too late and they have to travel, my mom has to take a day off from work to get to the dentist because it's so far away. We can't get dentists in rural. I would love to see that law that the dental hygienists can do simple caries and whatnot. That would just be so wonderful. We have a great gal in Pennsylvania, Kelly, who's a dental hygienist and teaches actually at Penn State. And I know she'd be an advocate of that as well. So, I would just, you'd still have to watch the 51 because dental is not primary care for sure. Okay, good. Volunteers, we already talked about. How your refrigerated medications are handled. Every person should have power outage as one of their, who doesn't have a power outage? I don't care what state you live in. So how are you going to handle especially your refrigerated medications in a power outage? You must be able to answer the question. Do you have to have a generator? No, but what's your process? Is there a data miner that's going to buzz your cell phone, and you're going to go move those drugs, whatever it is, just make sure those drugs are safe. The answer is not, well, we'll throw them all away Monday morning. I've had that answer. It's not an answer. First of all, it's terribly wasteful, but it's not an answer. Okay. And then training. The only way the surveyors know that you did your training is by that training log. We're not going to ask every person in your clinic every question about your emergency preparedness. Okay, so make sure you have a training log. It says a subject matter at the top. It's got signatures and dates. It's not a printed list of names, because that's not a signature. Okay, and then you'll be fine on the training. All right. And training is every 2 years unless something changes drastically. And we've had a lot of that recently. So make sure you got that. So your full scale exercise is every other year, and in between can be a tabletop or some kind of simple exercise, right? Your event counts. We have clinics with events running now 3 years in a row, right? I'm sure Florida's going to have a few that are going to use this Ian as their person, maybe South Carolina too. But you have to have it every other year unless it's a real event. You don't have to do a full scale every year, but you want to exercise your plan. So I got a call the other day. Can I use monkeypox as my exercise? Oh no, event. It was event. And I said, well, if you would explain to me how monkeypox has challenged your emergency plan, I'd be delighted. Well, it didn't. They're talking about it on the news. They'd never even seen a case. They're trying to prepare, so that's not acceptable. So it's when you activate your plan. You know, Florida did. You know, we all did in COVID. And it was very different in 2021 or 2020. Now, years going by here, when we didn't know a lot about COVID. We're putting signs on the doors. We're taking everything out of the waiting room, including the chairs. We're telling people to go back to the car. That was a different write-up, after action report or hot wash, whatever you call it, than it was in 2021, where now we're vaccinating and testing, different whole subject. And so it was acceptable 2 years in a row. It was very different. Make sure the most common thing, it's probably on the next slide, I'll say it now, missing is the evaluation. What did we learn? You must write it up. And what did we do about it? So maybe it was hand sanitizers on the first one. We learned we didn't have enough, and good Lord, we couldn't. I had masks. I was sending all over the place. A friend of mine was sewing them. I was sending them everywhere. They probably weren't the best masks medically, but we needed masks, right? So they were sent out. So what did we learn by that exercise? I don't know how we could have known that was coming and had lots more masks and hand sanitizer in our clinics, but there, at least you would write up an evaluation of what you found. Another common deficiency is abnormal labs. So if the surveyor is doing a chart review and they see an A1C of 14, there's no note in the chart that says the patient was notified and here's our plan, that's going to be a citation. Okay. So make sure that they're documenting those things. All right. And what instructions were given to the patients. The biennial evaluation was a great misunderstanding that was under waiver. It was not under waiver. You still had to do it. Did you have to have a meeting? No. You had to have a report. You had to evaluate your clinic and what was going on, the number of patients seen, all those things that go into it, review of policies. And you could pass it around through emails or paper, whatever worked, but you did not have to. There is actually no requirement for a meeting in the regulation. It's a great way. It's good practice to sit together, have all the data, and let's talk about it. Let's see what we need to do better, but there's no requirement for a meeting. So let's be clear on that, because people really think that too. And we've had a number of people with failed survey because they didn't do the biennial. So you want to make sure. So have your clinics, always ask them, look at it now. What's the date? Is it more than 2 years old from right now? And if not, let's get one going. That is a very hard thing to fix in 45 days. You're very busy and you have a lot of work to do to fix that. Okay. So medication administration records. One of the things we do when we look at a multi-dose vial that does not have a date on it is we look back in the charts and look for that lot number and see when it was administered. Find out when it was used if it's more than 28 days, and we'll give them that if we find it. Can I find it in your EMR? There is MAR and just I don't think there's an EMR that doesn't have that. No, I don't think so either. So make sure and that the allergies are noted. Okay. I put all the regulations for the vaccine mandates survey in here. I'm not going to read these, but let me just tell you what's going on. So far in Florida and Texas. The federal government has hired contractors and they are doing COVID vaccine surveys, 4 hours long, looking for documentation of your policies and are your people vaccinated. So make sure you I don't know if it's going further than that. I have I've only heard of those 2 states. Whether it's going further, I don't know. You want to make sure. So we had a clinic that failed because 100% of the people were vaccinated and they had no policies. They didn't, what do we need that for? We're vaccinated. Wrong. So 491 AD, make sure you read this and it's all there. I'm not going to go through all that, but you must also have a log. Think of it as a spreadsheet. And on that spreadsheet, you have every person's name that works in the clinic, whether they're vaccinated, whether they're boosted, not required to be boosted, except California. And there might be other states, but I know about California. But you have to track the boost that's in the law. Okay. And those that are medically exempted, those that are religiously exempted, and those that are on hold, all on that log, and they're looking for that. So it is required, but again, this is a different group. They're very serious about this at the federal government. We want to make sure that we're in compliance, okay? Staff that are 100% off-site at home doing telehealth would not have to be vaccinated. Let me tell you about a hospital survey. We don't do hospitals, but a hospital survey where the survey team was in the lunchroom for a hospital, and there was construction in the parking lot adding on to the hospital. And the construction team came in to eat lunch in the cafeteria and use the restrooms. And one of the surveyors for the survey team, a very large national hospital survey team, well known, went up and asked them some questions. They were mostly not vaccinated. The hospital failed survey. That's a big deal. So you got to know who's coming in your building as a clinic or hospital for that matter. So if you have regular visitors, drug reps that are stocking your sample closet, you want to make sure they're vaccinated. All surveyors have to be vaccinated, state accreditors, we can't work without that. So not even exempted. So we're all, and you're actually not even allowed to ask, but we are all vaccinated. But these other people coming in, make sure. Now, if it's the cleaning people, Michonne, you may disagree with this, I'll ask. If it's the cleaning people who come in at night and they never see any person, I wouldn't care. You agree with that? Yeah, good. Okay, we're on the same page. That's nice. It's a risk. But still, that would be fine. They're not interacting with any of your folks. Okay, so the big question on the masking, I know masks are relaxed now in the clinics and in the hospitals. Anybody? Not yet? Hospital masks still? Nobody knows. State, up to state? Yeah, so some will be. But if you have a person that's exempt, how are you going to keep them safe? What's their job going to be? What's your job to keep them safe? It is your responsibility because they are exempt by your policy. You're going to have a medical exemption policy, which follows CDC guidelines, and you're going to have a religious exemption policy, which is your policy, and no one should question that policy. It's your religious exemption policy, but you got to have one. Can't just have them sign. Okay, there's a lot. This has really, so my point on these slides is your clinics are dealing with a lot right now, a whole lot. They're understaffed and they have all this stuff going on. So, and then they don't know which waivers are going to end and what it looks like. So really be conscious of that, and always can come to me for questions anytime, always, never an issue. I think I covered all of that. That's all the vaccine. 5 minutes? Okay, we're good. We're right at the end. Okay. So after the surveyors are done or at the day, they're going to ask staff questions, and you should do that or teach your clinics to do that if they're doing a self-survey. You don't need to know the answer to everything. You need to know where to find it. One of the things when I talk to managers is that they are the wealth of information of the clinic. If they happen not to be there the day the surveyor walks in, things can go sideways very, very quickly because they can't find the stuff. So share the information. It's not a one person's ultimately probably responsible, but everybody should share that knowledge. We always ask, what do you do to evacuate the clinic? It shows they may never have had a fire drill. Very simple thing. It's not about tornadoes or a chemical leak somewhere. It's about a fire drill, really. They should know that. So that they should know, answer questions for their job and where to find information in general. So surveys are all unannounced. We show up, we take usually 6 to 9 hours. 9 would be a very large clinic, and then have easy access to policies. We're fine with intranet policies, not in a hardbound book, but you run the risk that it's out that day and then we can't see it. So you have till 5 o'clock to fix it. We haven't had a problem with that, but it's so much easier to keep them up to date electronically than in paper, and how many copies you've got with policies all over the place. And then the exit interview to tell you what we found. And they should do that with their staff. Oh, and that is somebody else's name who works for me. I didn't change it. She's going to Iowa for me next week to speak, and I did these slides, so I apologize. Same phone number you can get me, and it's khill@thecomplianceteam.org. Oh boy, any questions? It's been a day. Any? Yeah.
They invite you in, or are you
So about 6 months, maybe 8 months prior to their expiration date, we would have to see them by that date. So they get a letter from us with a renewal contract, and that's when they make a decision. Most renew. Yeah. Hopefully we offer them the service to stay with us through the 3 years. Yeah. It's very different. I've got a clinic coming up in Wisconsin, and I know there's going to be like 10 people following that poor surveyor around all day. It is what it is. It's their choice. So we send one on a normal size clinic. Sometimes we'll have a group of clinics, 4 and 5 clinics in a system, health system, where we'll send a team. Depends on the size of the clinic. Some clinics, you have to check the HIPSA. They're like 60-room clinics. And you wonder, is it really rural? And they are. There's some really big clinics out there. Yeah. Yeah. So we get this question a lot. People try really hard to squeeze it out of us. CMS would fire both of us if we told you when. Sorry. We'll give you the window. We'll let you know what the window is when we're coming. Medical exemption, how often reviewed? Boy, we haven't been in it long enough for that to be a question yet. Well, I guess it would be the reason if it's an allergic reaction, I wouldn't need another review. If it's a pregnancy, we better go back and revisit that. That would be more a hold anyway than an exemption. Yeah, interesting question. The question was, how often is a medical exemption reviewed, for those of you listening? And I don't have a clear answer on that, but it would depend on the type of exemption, the reason for the medical exemption. No, there isn't one. So we had a question with a religious exemption on dose 1. No, they took dose 1 and the religious exemption came for dose 2. Well, that's really hard to buy. So yeah, that wasn't really real. So it's your policy. You have to decide and be able to back it up. Yeah, it's a hard one. All this is challenging for everybody. Any others? No? Thank you much.